sponsors of the Wisconsin Health News panel series. These important and valuable discussions truly would not be possible without their support. So a huge thank you to Ascension Wisconsin, Advocate Aurora Health, Group Health Cooperative of South Central Wisconsin, Husch Blackwell, Marshfield Clinic Health System, and WPS Health Solutions. Wisconsin Health News is a nonpartisan, independent online news service. In addition to hosting events like these, we also publish a daily email newsletter. If you're not yet a subscriber, I encourage you to sign up for a free trial. You can do so by signing up through the event evaluation, which we will send out after today's event. Or you can also sign up on our website at wisconsinhealthnews.com. An extra thanks today to Marshfield Clinic Health System, today's featured sponsor. Marshfield is a longtime and generous supporter of Wisconsin Health News. We are so grateful for all of their support. Here to say a few words is Marshfield's Chief Medical Officer, Dr. Bill Melms.
Thank you, Tim. And in a moment, we'll be hearing from our panelists, but first, I want to thank Wisconsin Health News for having us join today. Throughout 2020, along with the other healthcare providers in Wisconsin and in the nation, we at the Marshfield Clinic Health System look forward to the availability of vaccines as our way out of this pandemic, the light at the end of a long, dark tunnel. When the emergency use authorization was provided, we immediately created the infrastructure needed so that we would not be the limiting factor in the administration of vaccines. We made sure that any dose we were allocated, we could administer. And for the first few months of our vaccination effort, the major challenge that we faced was that of demand management. Supply and demand simply did not match up, and our wait list grew. More recently, and thankfully, the supply has caught up with demand, and we now face a new problem, that of vaccine hesitancy. Our efforts have been redirected, and we'll get through this as well. The pandemic isn't over yet, and we still have a lot of work to do. Thanks for joining us, and I look forward to hearing from our panelists.
Well, thank you, Dr. Melms, and thank you for all the great work that you guys do. And thanks again to Marshfield for all of your generous support. So we are focusing today on the state's COVID-19 rollout, COVID-19 vaccine rollout. Nearly 1/3 of Wisconsin is now fully vaccinated, and more than 42% have received at least one shot. Nationwide, this initial phase of the vaccine rollout has, I think it's safe to say, exceeded even the wildest expectations from a year ago. But as Dr. Melms alluded to, there's still a lot of work to do. As supply of the vaccine catches up with demand, and in many respects, the biggest challenges of this process remain ahead, reaching out to hesitant and holdout residents in an effort to achieve some sort of herd immunity. Meanwhile, more infectious variants of COVID-19 have in recent weeks caused case numbers and hospitalizations in Wisconsin to increase. So we have a lot to talk about. We have a wonderful group of panelists to learn from. So I'm just going to dive into the questions. And Kirsten, let's start with you. First of all, welcome back. We've had a chance to already work with you in one of these webinars this year. Your first Wisconsin Health News event as Milwaukee Health Commissioner. So thanks again for doing this. I want to start by talking about where the vaccine distribution is in Milwaukee. It was recently announced that the mass vaccination site at the Wisconsin Center will close at the end of next month. This was not unexpected, but as we shift to vaccinations and more community type clinics, is the announcement of this and the lag we saw at the site in terms of demand a sign that we're already getting to this point where the first eager group has gotten their COVID-19 vaccines?
So I think what we saw initially, and all of the panelists can speak to this, is we had more demand than there was vaccine. And then for a bit of time, we had vaccine that was meeting demand. So at the Wisconsin Center, we were doing upwards of 3,000 doses a day. But we're realizing now that we have ample vaccine and that we have more vaccine than we have demand, that these mass vaccination centers are not as effective as meeting people where they are in the community, or where they go to their primary care provider, or where they're more comfortable going to a pharmacy, for example, or a neighborhood organization or a church. So we're really trying to pivot and meet people where we are. We have this really high demand to begin with, where a mass vaccination site is completely appropriate, but we're now moving through into a new phase where we need to get out into the community to make it as easy as possible for people to be vaccinated.
So it seemed like really not too long ago that people were clamoring for their COVID-19 vaccine. There was concern about people skipping the line. Are you concerned or at least surprised that we've gotten to this next phase as soon as that we have?
I wouldn't say I'm surprised. I think we all anticipated this would happen. I think what surprised me is how quickly it happened. I think we thought it would phase more slowly into this space, but it happened in a matter of like 4 or 5 days. We had significant demand, and ironically, it coincided with when we received a lot more doses in the city of Milwaukee, and suddenly we had less demand. I think we all anticipated that it was going to happen, just maybe not as quickly in terms of time. Literally, we had demand, and then it really started to trickle off.
So what do you think is causing this beginning stages of a slowdown? Is it vaccine hesitancy? Is it access issues like transportation and childcare and work, all the above? I mean, what's your assessment?
I think probably all of the above. If we think about who's been vaccinated, where the high demand was to begin with, if you look at our population of individuals over the age of 65, a large percent are vaccinated. So those who are really at highest risk of disease, we're most interested in being vaccinated. Many of them have gotten vaccine and have made an effort to get it. And we've, as a state, made an effort to get it to them as well, and as a country, thinking about going to long-term care facilities and who had access right off the bat. I think this phase that we're in, if you look at traditional flu vaccine rates, we're right in that 41% in the city of Milwaukee of individuals who have at least received their first dose. Interestingly, we just recently, actually today, got data on specific census tracts, and we have a variation in the city of Milwaukee of 16% of one census tract has gotten their first vaccine to almost 90% of another census tract. And I think that's really where we need to focus our efforts. And if you look at the census tracts that haven't been vaccinated, they are those high vulnerability, issues with transportation, childcare, work, all those pieces. Again, I think the key here now is to meet people where they are and to make it as easy as possible for them to get the vaccine.
Thank you. Dr. Izard, let's shift to you. Welcome back as well. We were thrilled you could do another one of these virtual events with us. In the communities that you serve through Milwaukee Health Services, what type of take-up are you seeing right now for COVID-19 vaccine?
Well, I say there's still a lot of people who desire to be vaccinated, but they're trying to look for the correct opportunity. So as Commissioner Johnson was just mentioning, opportunities for community-based events, things that don't require multiple bus routes or for you to have to travel across town. Those are the things that really drive issues. Like the vaccination does require that community participation. So you actually want to create a certain positive hype around it, with appropriate scientific information, health information being provided. But being able to show literally in the neighborhoods where people live and work. We just did an event this past Saturday at our clinical location, which is in central city area of Milwaukee, and had a very good positive response on the south side with the predominant Latinx community. Has had some very positive responses. So what people are looking for is to receive the vaccination in conversations actually from people they're familiar with, so that they can really feel like they can trust what they've been hearing, because there's so many mixed messages that are actually coming out, even from public health officials and politicians. There's so many mixed messages that people still are just concerned. They don't really know what to do.
So for those of the patients that you work with that have not gotten it yet, what would you say is that breakdown in terms of they're hesitant, they're not sure about getting it, they don't want to get it, versus access issues like not being able to get to the appointment or having childcare or work conflicts?
Well, I would say the vast majority of the people. So what we do at our clinic and what I do with my patients, I always ask my staff, if someone's scheduled an appointment for whatever follow-up visit, please ask them, have they been vaccinated and are they interested in being vaccinated? And so by the time it gets to me, I'm able to assess whether this person, where they may position themselves as far as the vaccine. And I would say of the people who come to me, in part of that conversation, and who say that they didn't want it, the vast majority after a conversation with the doctor actually end up taking it. And so what ends up happening is initially people have their concerns because what we're just all talking about there's just so many mixed messages that are actually going out there that people almost get stuck. And you've heard me say before, when it comes to influencing behavior, you have to not only provide, logic, reasoning, education, information, but you also have to have credibility. You also have to address their fears in real time, and you have to prepare a plan that is considerate of the cultural beliefs. And so when you look at it like that, all four of those components need to be incorporated into every conversation. What we failed to do is we provided way too much conversation only on education and information, and failed to address credibility, the fear factor or concern factor components, and cultural beliefs. So most people, after they finish having the conversation with me, I'm literally asking them, all right, what is it that is preventing you from making the decision? And as we go through that process together, I tell every single patient, my job is not to tell you what to do, but it's to help you identify what is your individual goal as a family, as a person, and as a family. And now let's look at the consequences, the pros and the cons of the decision either to take the vaccination or not to take it. And as they go through that process, they realize that, well, for me to accomplish my family and my life goal, then I am much more at risk by not taking the vaccine than taking the vaccine. So in the end, I never told them to do it, but they come to the resolution themselves and they feel a lot more comfortable. It not only addresses the cultural issues, it addresses the fear, and it establishes a new level of credibility that I have with them, that they can trust that I'm not just trying to sell them something.
Great. Thank you, Dr. Izard. Tim, let's shift to you. And I know it varies across the state, but what type of take-up are you seeing in the rural communities that you work with? Is demand still high, or are we starting to see a slowdown?
Before I forget, let me just say everything Commissioner Johnson and Dr. Izard talked about in terms of Milwaukee, I will say ditto for rural, although our context is somewhat different and may in the end be somewhat more challenging. Tim, as I mentioned to you before, when you invited us to be on this panel maybe a couple of weeks ago, we weren't at the tipping point. So I was going to be outrageous and bring up issue of vaccine hesitancy. And now all of a sudden, that's what we're talking about. And that's what Commissioner Johnson referred to, how quickly this changed. And at least for me, it was much earlier than I had thought. It is troubling because I think what it means is the pool of people in rural Wisconsin who are wanted and were ready to get the vaccine was somewhat smaller than I had anticipated. I have been tracking the data that DHS provides on their dashboard, and was really kind of proud to say for months, there's pretty much parity between rural and urban, looking at a county level population. Within the last small number of weeks, I've started to see slippage. So now the rate for rural is 88% of the urban rate. And every time I check, it keeps slipping further. And I'm not really a scientist or anything, but that speaks to me that we're finding fewer and fewer people who are willing to take willing to take the vaccine. A really great resource from a rural point of view is a study, a poll that was reported by Kaiser Family Foundation just in the middle of last month. And I guess that I was beginning to get concerned, and that made me more concerned. And I'll just give you a couple specifics from it. It says that 60% of rural young adults, and they define that as ages 18 to 49, say definitely not, or only if required, or wait and see. 60%. 59% of essential workers outside of healthcare, 54% of rural white evangelicals. I think I've just described an awful lot of rural Wisconsin. So I think as hard and difficult as all the issues have been around to date around vaccination, I think we have our toughest work before us.
And what do you think is in these rural areas? What is driving this slowdown, do you think?
Again, quoting from Kaiser, they had three top concerns expressed by the national poll of rural individuals they spoke to. The first was, not surprisingly, that they might be required to get a vaccine, even if they don't want to. So it's a sense of government telling me what I need, or the elites or the professionals telling what I need. And that creates a they, it creates a divide. Second is they might experience serious side effects, but I think the kind of conversations that Dr. Izard spoke to is hopefully will address that. And that it's hard to believe, but the effects of the vaccine will be worse than getting the COVID. So these are, particularly the second and third, are issues that I think are amenable to education. I would add, though, I think, and I'm not suggesting that we get in a wrestling match with the anti-vaxxers, but I think we need to understand there's people who are spending a lot of energy, a lot of time spreading false information. And again, I don't think a head-on attack or wrestling match with those folks is the right approach. But I think as we strategize, we need to understand we're just not playing on a field where people, if we just give them some information, they're not hearing other opposing information.
And why do you think, I mean, if you look at the numbers across the state, geographically rural areas take up a pretty big part of our state, but there certainly is some variance. I mean, you look at a Bayfield or Door County, and they actually do have some of the highest rates, vaccination rates in the state, whereas counties like maybe Rusk are lower. What do you think is causing some of that variance amongst different parts of the rural parts of the state?
Rural and urban both. In fact, that's characterized the data, I think, since we've been collecting around vaccine is substantial variation. I think part of it is certain communities are more rural, they have fewer resources and so our work isn't done yet in reaching and dealing with issues around transportation or people who, for whatever reason, the access is not what it could be. I agree with those who spoke before me that local sources like the pharmacist, the clinic, the hospital, in communities that are really stressed relationship is a lot more important than any sort of large vaccination effort. I do think it's a mistake if we think vaccine hesitancy is kind of evenly spread like icing on a cake. It's anything but, and we have been asking for some time for the data we need from the state to replicate kind of the more zip code census track data that's available in Milwaukee, because we need to know where are those communities where there's more of a reinforcement systemic mechanism going on that's helping to fuel and sustain the vaccine hesitancy.
More and more analysis are showing that political beliefs can be a factor, with Republicans, especially Republican men, more hesitant to get a vaccine. And if you look at these numbers, I mentioned Bayfield and Door County before, they usually vote Democratic. Some of the counties with lower vaccination rates often vote Republican. Do you think it's fair to make that correlation? And if so, what can area lawmakers do to turn that around?
Well, I think the data supports what you said. I chose not to bring that up, but you brought it up, and I think again the data supports it. I think we need as much support and clear communication from across the political spectrum that this is a real issue. I will never, I'm probably a little older than most on this panel, although Dr. Conway seems to have a lot of white hair too. I've never experienced in my career a time so challenging. I'm glad that I've been able to be part of the work, but it's heartbreaking when I know what all of our colleagues have gone through, to know that there's people still saying that it's fake news, that it's really not a problem. It's those Democrats or some other group that are causing all the fuss. I think we actually are going to have a long-term challenge around what this period has done to how people think about medicine, how they think about science. I don't think this is a one and done problem around the vaccine. I think what we've made science, we've made medicine political, and I think that's a tragedy. I think the degree that we get respected voices at the local level, and quite frankly, I know some people think public service announcements are not what we need now, but I do think they help set a tone. To the degree that we have conservative speakers from our legislature, from our churches, from our business community, speak their truth on this issue, I think that will help.
Well, thank you, Tim. We'll come back to you, but I want to move on to Dr. Conway now. Dr. Conway, are you surprised that, at least in certain parts of the state, that we are already starting to see a slowdown in enthusiasm for the COVID-19 vaccine.
Yes and no. And I think one of the things that I wanted to reflect on in sort of response to what my partners here have talked about is that vaccine hesitancy is sort of one piece of a bigger puzzle, which is this whole idea that I've been trying to bring people around to of COVID complacency. And one of the things that we think about is how do people view their particular risk for themselves and their families? And I think that there are large numbers of people in large areas of the state where people feel like things aren't that bad and that they're not actually at particular risk. And so their motivation to go out of their way to actually go find an opportunity to get vaccinated isn't particularly compelling. And so I think that, what has happened in many ways, and obviously it's a complex conversation, is that the negatives that are out there as far as misinformation about the vaccines is enough to basically push people into staying in their complacent state of saying, look, this isn't so bad. The state's gotten it under control with mitigation stuff. And these are the same folks that also, would push back against masks and other mitigation activities that we have. So I think that the vaccine hesitancy, I think that's oversimplification of a bigger issue. And I think Tim speaks to the fact that, science has been under threat for many years. It predates any of these last administrations. This has been something that's been a constant as people unfortunately see science done in a more transparent way. They don't quite understand how science happens. Science happens only as we reproduce and redo and improve things over and over again. And so, early on when there were these papers being posted before they had even been adjudicated and refereed that purported to have sort of that week's answer, and then a week later, okay, we do need masks after all. Like, that's how science happens behind the scenes, but it needs to happen in a way that people can understand it. And so what Tim was talking to, and what everybody's been talking to, I think is a bigger conversation about how do we impress upon people both what the threat is to them and their loved ones, what can they do to contribute, and how do we normalize the behavior of sort of pitching in together and functioning together in a way that actually preserves the wellness of all of our communities.
And so how does that compare, and how so far has this process compared to the flu vaccine and take up for the flu vaccine?
Yeah, I mean, this has been sort of the flu vaccine in a microcosm, but in a kind of sped up fashion. I mean, every year, and it's interesting when Tim mentions the Kaiser Family Foundation, we've been working with them for many years looking at flu uptake and flu vaccine refusal. And the reasons that people refuse flu vaccine match up almost identically to the reasons that people choose not to get the COVID vaccines. And so while this has been done in a relatively brisk period of time and a really, in some ways a medical miracle in a kind of a heroic fashion that we've been able to get these vaccines to be available, people that are believers and are on board with sort of the normalization of vaccines have been pretty quick to adopt these as what they think is the norm that they and their families should jump into. People that have been doubters have been out there and have been doubting for a long time. People that have mistrusted science and mistrusted the medical establishment have mistrusted it for years. And this is just highlighting a lot of very deep and very important challenges that we have in healthcare that are just being highlighted and are now on the front pages. But most of the group that you have assembled here, these are things we deal with all the time. Whether it's contact tracing and people's reluctance to give up names of people they've been around, that's been around since, people invented sexually transmitted infections. So we're basically just sort of seeing everything that we deal with and are challenged by in healthcare and the health industry in a microcosm and in a very compressed period of time.
So usually annually about half the state ends up getting the flu vaccine. Do you, for all these reasons you just listed, do you have any hope that we'll do any better than that for the COVID-19 vaccine?
I do. I mean, I'm an eternal optimist because after you've been around for a long time, like Tim, you have two choices, and one is to be an optimist and the other one is to not be an optimist. And that one's not very much fun. I've had gray hair since I was 16, by the way, Tim. So my age belies me. No, but I mean, I think that I do have a lot of optimism that, this is a pandemic of epic proportion. And I think people are seeing that while it comes in waves, it keeps coming and it keeps reemerging in different areas. And I think that the more that we can incentivize and actually make it a positive that people choose to participate in activities that get us out of this, the better we're going to have as far as compliance. And so one of the things that I am always concerned about is the idea of the carrot versus the stick. And that, I think that in much of our medical practice and public policy, a lot of these things are related to sticks. And I think that there actually needs to be more discussion of carrots, of incentivizing the behaviors and the activities that we want people to do, because we know that they're the best things for those people to do. And so I think that there's been more conversation around that. And I do think that if we can do what many people have talked about, which is bringing vaccine to people where they are and making it convenient for them to get it. We already had fought many of those fights over the last 15 years. When I moved to the state of Wisconsin in 2005, pharmacists could only immunize 18 and above, ages 18 and above. And we said, look, unless physicians' offices are willing to be open nights and weekends, we need a way that we can make it easier for people to get vaccinated. And so, despite some people complaining about undermining the medical home, many of us went to bat on behalf of getting more convenient opportunities for people to be immunized. I think bring vaccine out to communities and mobile clinic opportunities is a way of actually doing that, as long as it's done with people that are from that community, ideally, and that are trusted and part of that community. But I think we have ways of incentivizing this and making it something that people can feel good about, that they can feel they're protecting themselves and their families, that we can answer their fears and their questions. And Tito's absolutely right. You need to listen to people first and figure out what is it that are their concerns, and figure out not only what do they need to hear, but who do they need to hear it from. And I think if we can figure out better ways to do that, better ways to hear and listen to what's happening in the communities, I think we can address those concerns and at the same time make these things a lot more convenient than they've been. I mean, we've done a good job of making it convenient, but we can do better.
Thank you, Dr. Conway. So we're going to come back to you, but I want to come back now to Commissioner Johnson. Commissioner, the federal government recently said that it was okay to start using the Johnson & Johnson vaccine again. How is the city going to use this vaccine going forward? And is your plan changing at all after this pause to overcome any new hesitancy that's arisen due to this pause?
So I think the pause, what it demonstrated was that our system of identifying side effects to the vaccine worked. Unfortunately, it only fueled the conversation that it's not safe, which I think the FDA very carefully weighed that decision and really was concerned that there were going to be more people who had an adverse effect. And unfortunately, that was not the case. And we at the city have been using it at our mobile clinics and shelters. It's really easy to transport and administer. We are hopeful that we're going to use it again, and we'll use it upon request. We actually did a partnership early on with Dr. Izard and a Greater New Birth Church, and it was very effective, and we vaccinated over 800 people. And again, it's one dose, so it's very easy to use in that mobile clinic setting. And I do think we're going to be faced with people who just don't want it, and we need to respect it. As Dr. Conway said, we need to listen and have other options available. So our plan moving forward is we will have Johnson & Johnson. We will use it as soon as DHS gives us the green light, but we'll use it for people who are asking for it. We'll use it at our mobile clinics, but also have an additional option. We'll continue to use it in our shelters, again, with an additional option for people who are uncomfortable. But I think it's really about listening and answering people's questions. I mean, to the point around hesitancy, which I don't really like using the terminology hesitancy, I think it's really, again, about people are concerned about the vaccine. It came out very quickly. And I understand that in 1999, I did a vaccine distribution in Mali, West Africa with the Gates Foundation. And, it was very much about going door to door and having the person who's bringing the education and who's the messenger had to be the appropriate person and really listening and answering questions so people felt comfortable for their children to get the polio vaccine. And I think we're in a very similar, 21 years later, it's just the same thing. It's about meeting people where they are, addressing their concerns, treating them that they're human and their concerns are valid and that they deserve answers. And I think, again, bringing the vaccine out to communities is really into people where they are is how we're going to get through this. And to Dr. Conway's point, get past the 50% where we usually see flu vaccine.
So, Commissioner, last time you were on a panel with us in your role with Ozaukee and Washington counties, we talked a lot about how strained public health departments were. It's certainly something we've written about and has been talked a lot about over the past year. I mean, does the health department have that type of capacity to do this type of more focused outreach that it sounds like will be necessary during these next phases? And if not, what type of partnerships are you going to be looking at?
Sure. I think we're trying to leverage all the partnerships. There's a fair amount of sort of outreach or education. I don't exactly know the terminology for this. Some dollars that came into the state, they actually went to the entire state. But the city of Milwaukee has an ambassador program. So we trained 100 people who are either formal or informal leaders in communities. We gave them a training around COVID and the vaccine so that they are armed with the information so they can answer questions to their own personal sort of networks. And so again, sort of trying to leverage individuals who live in these communities, who live in our communities, who live in the city, who live across the state, who are from the neighborhood to answer people's questions. So again, meeting them where they are. And I know many other organizations are trying to leverage those same partnerships and relationships to try to get information out.
What type of specific steps do you anticipate taking with businesses during this next phase?
So we've actually been reaching out to businesses and offering vaccine clinics. So we, for example, did Palermo's this weekend, and actually Palermo's is a great example. So initially they had said to us they think they have about 500 staff who are interested. Turned out they had about 120 people that we vaccinated, or 130. But the folks that we vaccinated, they were highly, I think we had to have 7 or 8 different language translators there. They're people who are unlikely to show up at a mass vaccination clinic for transportation issues, that maybe were uncomfortable, don't have a medical home. So we met them where they were. They were at work. It was convenient for them. Their employer was trying to facilitate that. We brought all the resources we needed to answer their questions and get vaccine in their arms. And I think so we've been offering those similar services, but I think, again, meeting people where they are, where they're comfortable, is how we're going to address this.
And so how responsive have businesses and maybe other community partners been to that? I mean, does Palermo stick out as an exception, or is that maybe the norm for other businesses that you've reached out to?
I think that's going to be the norm. I really think that we're all in this together. I think there's a collective sense of responsibility that we all want to be able to go, we all want to be able to enjoy the summer and the events that we have in Milwaukee and throughout the state of Wisconsin. So I do think that that businesses are receptive. And in terms of our staff, I mean, we have staff working at FEMA, right at the FEMA site at Wisconsin Center. We do have some capacity. And again, we are leveraging the relationships we have in the community to be able to do this work.
What type of restrictions, precautions are still going to be needed in the months ahead as these vaccination rates do increase, but before we reach any type of herd immunity? I mean, do you think that things like vaccine passports, allowing some businesses to maybe ease restrictions before others if they require vaccinations, do you see any role for something like that?
I think we're in this space again. It's a novel virus. This entire year, we've sort of been building the plane as we're flying. I don't think this is any different. We're learning in terms of vaccine passports. I think the challenge there is they could potentially be, people could falsely identify themselves as being vaccinated. I really think this is a time for us as a nation to think about data and interoperability and how do we share data. So investment into data systems, I think that would help us get to a place where we could have a vaccine passport. I know there are a lot of conversations around them, but I'm just not sure we're in that place where we can say that they could be effective. And again, I think, today President Biden came out and said that people who are vaccinated can be outside without masks on. So that's news and an incentive that hopefully incentivizes people to go and get a vaccine because they could eat outside at a restaurant without a mask on. But again, it's challenging because we're learning as we're moving forward, and I'm hopeful, but we'll see.
Do you anticipate the city will have to keep some restrictions in place going forward during these summer months as we get to that place where vaccinations rise, but before we can get to herd immunity?
I think so. And actually, our numbers of cases have increased over probably the last 6 weeks pretty steadily, slowly but steadily. We are just starting to see a downturn. So it's likely we're going to have restrictions in place for a while.
Can you see a situation in which COVID-19 vaccine would be required at any level?
So that's a great question. I struggle to see if that would happen. I think it may be very similar to our childhood vaccines. So when you enter kindergarten, you have to have a certain series. Parents can ask for an exception. I think it's likely that we'll see something very similar. And potentially even so for flu vaccine, there are employers, so healthcare organizations who may require flu vaccine for individuals to work on certain floors or have an exception. I think it'll likely be very similar.
So nationally, there are more and more reports of, for a variety of reasons, people getting their first dose, but then not coming back for the second dose. Are you seeing that at the city yet? And how big of a concern would that be if that trend continues?
So it's actually less than I initially anticipated. So I just assumed we'd have about 10 to 15% of people who wouldn't return for their second dose. We think we're right up there with the national average, between 5 and 8%. But we are working now at the health department to go through the lists of individuals who've received a first dose and not returned for their second, and calling them to remind them and give them options for their second vaccine.
Great, thank you, Commissioner. Dr. Izard, let's go back to you. When we talk about vaccine hesitancy and access issues, a lot of this can be tied to longstanding health disparities, which have undoubtedly been exacerbated by the pandemic. And as you've talked about a lot in the past, there is not a simple solution to this very complex problem. But what are some steps that you think can be taken now to start to correct this and overcome some of these immediate barriers to getting the vaccine?
Well, I think let's start off with this whole discussion, which Dr. Conway is also saying. We really need to move away from this conversation of herd immunity, and because what has happened over the course of the last year, initially it made a whole lot of sense, but at least from my opinion right now and from the feedback I'm getting in conversations at the community level, I think we're doing ourselves a disservice by promoting this idea that we have to get to this arbitrary 80% threshold by vaccinations, because the reality is we're setting ourselves up for a huge failure. When you look at the fact of the number of the population that are under 16 right now who have no access to the vaccine anyway, and then you add on, Tim, what you have already mentioned, looking at the different population groups that have a lot of concerns, that have at least a delay in their vaccination, the reality is the numbers do not add up. The numbers do not add up of getting to this 80% threshold based upon a vaccination strategy alone. Okay, and so we really need to have a different level of a conversation. It's still just as effective, but really trying to meet people where they are with their questions and establish realistic expectations. The reason why so many groups are hesitant, and not this vaccination hesitancy, I actually refer to it as population groups who are refractory to care. And there is a certain level of in healthcare, oftentimes we call people non-compliant. And again, we set the label on the individual of their failure to meet our standard of expectation, instead of the reality is we failed to meet their need by addressing their need or concern. So we start thinking about populations who are refractory to care populations, and I actually refer to the population groups as HEED groups. So health, educationally, and economically disenfranchised populations. This is not an issue of people of color. This is not an issue of BIPOC, Black, Indigenous people of color. This is not an issue of Republicans versus Democrats. I think what we do is we create this, binomial approach to addressing people as you're either a 1 or a 0. And the reality is there are many things in life and in healthcare that there are contradicting or direct conflicting opinions or positions that both may be true at the same time. And what we fail to do is to think 360 degree, thinking about people are a whole. They're not just one or the other. And so we try to put people on one side or the other side when the reality is both of their ideas can be the same. So for example, when we talk about resistant populations, who are the most extremes the way we've categorized in America? We would think that the white Republican male and the Black American, especially American descendants of slavery, they would be in society the direct opposites in what most people would think. But the reality is those two groups of people share very similar ideas regarding COVID-19 and vaccinations. Again, we're labeling people. So I like to say, let's define things, let's not label them. When we stick with the definition, it allows us both to share in the explanation so that we establish what is our expectation, so that when our experience occurs, when your expectation exceeds your experience, that gap results in stress, frustration, and it reinforces the refractory to care issue, okay? And so our goal in this conversation is to stop trying to label people into a category and to really focus on what is the need that needs to be addressed in that process so that we can use the evolution of science and information as the process. Transparency is our best weapon against the opposition, people who are presenting false information. All right. The problem that we have isn't the opposition, what we would call people the opposition, right? And ideas the opposition. The problem isn't that. The problem is our lack of transparency. If people could see with their own eyes what's going on, then they would be able to refute those who are providing them with false information. And I think that needs to be our goal. So when we look at this whole issue of health, economically and health, educationally, and economically disenfranchised populations or heat groups, the issue is that when it comes to healthcare for that particular population, in particular American descendants of slavery, there has never been a level of parity when it relates to health. And you've heard me say, health disparities are a direct consequence of being an American descendant of slavery. So when you look at every single component, whether it's health, whether you're talking about wealth position, whether you're talking about educational attainment, whether you're talking about income level, whether you're talking about home ownership for the American descendant of slavery, none of those results exceed 60% of the white threshold or the white median number. Okay, so what is that? 3/5. 3/5 for African Americans has a historical context. So we can say when it comes to your rights as a citizen, your life has never exceeded 3/5 of that standard. That is the problem. Okay, it is not the people who are providing the false information. The problem is that we've never put in place an opportunity to create parity amongst people. And therefore the transparency has been lost. And until you address the transparency in real time with real people who have real credibility, you will continue to chase after something called herd immunity that will be an elusive goal. You need to be honest and tell people, be honest and have honest conversations as far as what this actually looks like.
So Dr. Izard, and you said a lot of great things there, but if we just kind of pinpointing the herd immunity point, if this is a goal that can't be reached, if the number is 75, 80, 85%.
It can't be reached by vaccination alone, I say.
And then so how do we have a way out of this then? Do we have a way to get back to a situation where there aren't precautions that we have to take or restrictions that have to be put in place? Do you see, and I don't want to use the word normal, but do you see a situation in the near future where we can get the virus under control if we can't reach that goal?
Well, so whereas Dr. Conway is an optimist, I would say I'm a pragmatic optimist, okay? And so what I do is I look at the reality, I meet people where they are, and instead of denouncing them or making them feel bad for their position because their position interferes with my goal, right, of herd immunity. Well, our conversation becomes looking at what do we want to attain and developing the realistic expectations of what life will look like if we make certain choices, okay? So in that process, herd immunity can develop, but I think what we are doing probably inappropriately is thinking that we have a whole lot more control over it than we actually do. So herd immunity can develop by people either becoming infected and developing, a natural immune response to it, or by vaccination. And so it is the combination of those two together that may get us to this level. And so now the conversation with people is, well, would you like for this to occur through you receiving the vaccination, or are you willing and are you prepared to accept the consequence of you and your family members possibly being exposed and now have to deal with the sequelae or the consequences of that, which could be, are you prepared to be off work for 2 or 3 weeks if you get ill? Are you prepared to live with the possible chronic COVID-19 condition, this long hauler that may be developing? Are you prepared to have, your breadwinner, your family die knowing that your family has no health insurance? So it's not that you're not throwing this in their face as, do you want to die? But you're saying, well, let's methodically talk through what this actually looks like. Those conversations, when I've had it with people who were, what we historically call this resistant, it's not that they were resistant, it's like no one ever had that level of conversation. And the most recent person I just talked to said, you know what, I never thought about it in that level of detail. Whereas that person was, no, I'm not going to take the vaccine. But it's like, wow, I really have to think about that. And so what it did, it created, what Americans want is freedom. And freedom requires two things. Freedom requires the power or the ability to create a new option and the ability to make choices within those existing options. What we're trying to give Americans is to tell them you have choice, but not without options, or you have options without choices. You need actually both. And this is the issue when it comes to conservative principles and ideas, and which actually may have some symbiotic relationship with the way Black people think, is that Black people don't like the fact that our freedom may be limited because we've seen our freedom limited by healthcare in the past. Okay, so it is a draw to a historical thought or position, whereas the white Republican may be thinking in terms of freedom as far as I want options and I want to be able to choose amongst those options. This is where we can help people get to a solution. It may not happen as fast as we want, but it'll be much more productive because it's done through transparency.
Great. Thank you, Dr. Izard. Tim, I want to come back to you now. What role do you see rural hospitals playing in this next phase of the COVID-19 vaccine rollout?
I think rural hospital clinics, public health have done awesome work. It's been a real reminder how important it is having a decentralized health system with adequate coverage in our rural communities. And I think they're absolutely critical. I can't remember who mentioned earlier, but this is really not about so much the messenger. And rural Wisconsin is very relationship oriented. And so I think it's the issue. Rural hospitals are the local trusted provider along with the clinics that work with them or which they operate. So they absolutely will be part of this conversation. As you pointed out earlier, there's a fair amount of variance amongst rural for a whole bunch of different reasons. I do think it's important to me, and maybe not everyone would agree with me, that I see vaccine hesitancy, and I recognize the limitation of that term, but it's term of art generally used. It's an equity issue that we have to address. And I use the word equity deliberately because a lot of funding from philanthropy, from state and federal government is through the frame of equity. And I think there is an issue and a need for us to recognize that in rural Wisconsin, I would define equity as communities with some have more resources than others. And you mentioned that, Tim, earlier. I think equity lens means that we take that into account as we plan. A lot of federal money, state money is going into this issue of vaccine hesitancy. So I think we clearly want to see where our communities are in the most need and get resources into those communities. Another issue that makes this, I think, particularly important that we haven't touched on, but I know a number of folks nationally have warned us that of the worst case scenario, that we do a pretty good job getting the virus under control in much of our communities, much of our geography, but we leave islands of substantial virus activity. That just feeds into the very negative potential of variants that can be developed and then coming back into the vaccinated communities. So I do think there's a public purpose in addition to what Dr. Izard was talking about in terms of respecting the individual, which I totally agree with. But this needs to be a statewide national effort, and we need to understand in the day we're all one community. And I think hospitals will definitely be part of that ongoing acceptance of that challenge. We have so far and we'll continue to do so.
In a lot of rural communities, hospitals are the biggest employer in that community. Do you anticipate any of your rural hospital members mandating the vaccine for their workforce?
Good question. I think the discussions that I've heard pretty consistently are, and this may vary a little bit from Commissioner Johnson, that as long as it's under emergency use authorization, they're hesitant to do that. I think once that we go into, whatever the right term is, permanent authorization, I think we might see some. I think people, particularly given the relatively conservative nature of the communities our rural hospitals work in, that by no means for most would be their first way of addressing the issue. I think they're much more about, those deep conversations that need to take place and continuing that. Having said that, with flu, I know many of our hospitals do require flu vaccine, or they require masking of the employee if for whatever reasons they choose not to be vaccinated.
Thanks, Tim. Dr. Conway, I want to come back to you. First off, what do you think of Dr. Izard's comment that we're likely not going to get to 75, 80% protection of the state through vaccinations alone?
Well, I agree with him at one level that in some ways the whole idea of this big number herd immunity is sort of a false narrative, because I think really the way we have to think about this is thinking about things in terms of community immunity. So even if the whole state is at 80%, if you've got entire communities that are only at 10%, those are essentially tinderboxes waiting for somebody to drop a match in and have an outbreak. And so what we really need to do is equitably help people understand that everybody, in this country has freedom, and they certainly deserve the freedom to be free of this terrible scourge of a disease. But every community needs to own that and understand how to pull together to make that happen. And whatever combination of immunologic immunity plus mitigation activities that are appropriate to keep everybody in a community protected is what the right answer is for that community. But I fully agree that there's certainly some thresholds of herd immunity overall that will lead to gradually diminishing risk of transmission, but it's only as good as how good the protection is in your own immediate surroundings and within the community that you live in and circulate with.
So about a quarter of the population in Wisconsin are children who mostly are not eligible for the COVID-19 vaccine yet. Can we get to that state until all children are eligible?
I mean, with large portions of the population, I mean, there's 80 million kids under the age of 18 probably in this country, and so you're never going to get to the point where you have that entire population protected if we just immunize adults. And so that's the reason that we've had to continue performing a lot of these mitigation infection control behaviors when we come to children and children coming into close contact. I do think that vaccines are going to be important in children. But as we all know, parents are the most fierce protectors of their children for good reason. And so we can't just assume that the dosing and the administration of the adult vaccines is appropriate in kids, and that we can't, as much as we all want to get out of this as quickly as possible, we've already moved this as quickly as possible in a very safe manner. This is no time to start cutting corners. We haven't cut any corners in the development of these vaccines in getting them to where they are. And there's no reason to do that now. And so kids deserve the opportunity to make sure that first off, we figure out what's the right dose in each age group, and then make sure that the side effects are tolerable. It's going to take a little while. People need to be patient with that we can't rush into it. But I do think that we're going to need to have broad offering of vaccine into all age groups across the country to be able to get this shut down once and for all so that we can get back to whatever a new normal is going to look like. I think a new normal is possible, but I think a new normal is going to be a little bit more respect for the evils of respiratory viruses. I think masks in certain settings are going to become a norm. I think going into medical facilities in a winter month, I think you're going to be darn used to being in a mask, and I think people are going to appreciate that. Most of our medical colleagues, I haven't had a cold and I can't even remember the last time I had one. There are some silver linings in this messy cloud that we've all been in, and I think we're going to keep some of those. But to get there, I think we are going to have to get to the point where we can vaccinate children, yes.
What's your understanding of the timeline of when kids under 12 will be eligible?
Well, under 12, the companies are just moving into the 6 to 11 and then younger groups to figure out the dosing. And so they're trying, it's kind of like Goldilocks. You try doses and figure out which one's just right. And then you move that into a little bit larger population to make sure that as you get, you want to make sure that the 1 in 5,000 or 1 in 10,000 side effect, is identified in your studies, and make sure that you understand these things. And so I think that by the end of 2021, we'll probably have a decent amount of data in those younger kids. And I would anticipate we'll probably be able to immunize those kids in early 2022. I think there's a small possibility that it could be in late 2021, but I think people are going to need to be patient. I think the 12 to 15-year-olds are likely coming up sometime, midsummer would be a good guess. And I would hope that we'll be able to move into those younger kids, but it's probably not going to be towards the end of the year. And so people are going to have to be comfortable sticking with a lot of these same things we've been doing. And again, I hope some of them stick around. I hope all my colleagues actually start to stay home when they're sick. I am so tired of people, especially in healthcare, being heroes and coming to work even though they had a cold and a fever. Those days are over. That is not acceptable anymore. And I think we need to adopt that as a society and as a community that cares about each other. I mean, that's what this is all going to have to come down to, is caring about the people in my community and caring about others. And I think we can get there, because I'm an optimist, but it's going to take some work.
So I think I speak for all fellow parents when I ask, so what is this meantime period going to look like as we get adults vaccinated and the kids won't? Should parents of unvaccinated children just kind of continue to keep going with the same precautions and protections they've been doing over the past year? Or will there be, maybe an easing of at least some of them as more adults do get vaccinated and we do get things at least a little more under control?
Yeah, I mean, this is a great example of what I'm talking about as incentivizing vaccination and making it worth people's while to do it. So as we've gradually seen, vaccinated individuals can now spend time together indoors with masks off. That's a major move for people to be returning to normal. And so if we can say that as long as all the parents and all the other family members outside of the kids are immunized, that's going to be then the opening to start allowing more interactions and more mask-free activities, especially outdoors. And so that's exactly what we're talking about, is we don't want to be forcing people to do things. We want them to want to do these things because they're the right things to do, and because there's the right things to do for them and their families. So I think we will very well, when we get to middle school and high school kids being able to be able to be immunized, I think we will be able to come up with manageable operating procedures so that kids can at least have some more normality, especially outdoors and especially with other primarily vaccinated families. I mean, people figured out the bubble thing pretty early. Who do you trust? Who's going to be on the same boat with you? Who's going to behave the same as you? And, we all know lots of bubbles that were very successful. I think these are just going to be this constant modification of what bubbles look like as we get into the fall. And then hopefully vaccines start to be available for kids. And 2022 gets back to, being able to behave the way we want to behave.
Pfizer's CEO said recently that a booster shot is likely for the COVID-19 vaccine. How long do you anticipate COVID-19 vaccines being part of our life? Do you think this is going to be like an annual get your COVID-19 vaccine with your flu vaccine, or is this just going to be for another year? What are your thoughts?
Well, my magic 8-ball is a little too hard to reach over on my windowsill, but if I flipped it over, it would say, ask again later. I think that the bottom line is a couple of things. One, it's no question that there are variants out there that we're tracking, but I think, as far as being an optimist, most of the vaccines that are currently in use are actually holding up pretty well against those variants. I do think that, we're seeing that the immunity from the vaccines is actually quite durable, but I won't be surprised if there's at least a wave of vaccine updates that need to happen. I honestly initially did think that this was going to be like flu, where we're going to need to update the vaccines annually. I'm not quite as sure anymore. I think this actually may be something that we get periodically, maybe something like a tetanus shot, but I could easily see where we get to the point where we've got this under control, and this may actually, I still have optimism that this could actually go away. I don't think we're stuck with this. I think a lot of it depends on what happens globally and trying to equitably provide vaccines and control of this disease everywhere. And a lot of it's going to depend, as Tim said, on how much we leave certain populations vulnerable, where we're going to see ongoing circulation and variants emerging. So I think there's going to be probably at least one update round of vaccination. And then I think we're just going to have to see after that where this goes.
Well, thank you, Dr. Conway. We're quickly running out of time here. I do want to ask one final in the minute-ish we have left. I do want to ask each panelist one final question. This is how we've concluded most of our webinars over the past year. Commissioner Johnson, we'll start with you. What are you most optimistic about right now?
I'm optimistic that we are getting vaccine in arms and that we have a strategy in the city of Milwaukee to address people, like I said previously, where they are most comfortable, and that we have a capacity and really a team, a collective effort to do the work. I think that to Dr. Izard's point, it really is a matter of treating people humanely and as individuals and humans, and meeting them where they are. And I think I'm confident and hopeful that we have the resources in the city of Milwaukee to do it well.
Excellent. Thank you so much. Dr. Izard, what are you most optimistic about right now?
Well, I think as we talked before, how COVID has been the canary in the coal mine as relates to health disparities, that we all realize that progress is not parity for health, educationally, and economically disenfranchised populations. So I think most people are starting to realize there needs to be a much more comprehensive strategy to restorative health equity.
Excellent. Thank you, Dr. Izard. Tim, what are you most optimistic about right now?
I think given the service provided by rural hospital and physicians and public health agencies over the last year, I'm optimistic that people now more than ever going forward will appreciate the need to support the rural infrastructure.
Thank you. Dr. Conway.
Yeah, I'm optimistic about the fact that, despite all the differences people share, that there's so much more that brings us together, and that we've seen science and medicine pull together in really unprecedented ways in response to this crisis. And seeing public health and pharmaceutical companies and academics and all the other areas of medicine and health and science actually come together, put aside their competitive nature and really come together around this, I think has been very heartening. I hope we can keep much of this as we move forward. And I think there's also been much more appreciation from the public about how important public health is and how important it is to try to manage outbreaks and infectious diseases together. And I really hope that we can hang on to this and continue to work together to address all of these disparities and inequities that we all live with and don't need to live with on a regular basis.
Excellent. Thank you so much. Thank you guys all for really a great discussion today. Thanks everyone for tuning in, and thanks to our generous sponsors for helping make today's discussion possible.